Okay, let's think about this. A tiny, tiny kink in a pipe causing, well, huge problems.
Yeah, exactly. It sounds simple, but the effects are widespread.
That's kind of what we're diving into today with coarctation of the aorta in kids. CoA for short, right?
CoA,
Oh.
like the body's main sort of water pipe gets squeezed.
Yeah, and everything downstream is affected. It's like a cardiovascular detective story.
It really is. And we're going to unpack that today, specifically geared towards MSRA pediatric revision for you listening.
Right, using these great notes we've got, the plan is to cover everything.
Everything. Definition, causes, risks, how it works, what else it could be, who gets it, how it looks, diagnosis, treatment, prognosis, complications, the works.
Brilliant. A proper deep dive, then.
Exactly. Your streamlined guide to understanding CoA.
Okay, let's start at the beginning. What exactly is coarctation of the aorta? Define it for us.
Okay, so basically CoA is a congenital narrowing. You're born with it. It's a pinch point in the aorta.
The aorta being the main artery leaving the heart.
That's the one, carrying all that oxygen-rich blood. And this narrowing, it typically happens near where the left subclavian artery branches off.
To the left arm.
Yep. And an important point, it very rarely affects the aorta lower down in the abdomen. Think of it like a specific bottleneck on a major highway.
Got it. A bottleneck. So what does that actually do?
Well, the immediate effect is obstruction. It makes it harder for blood to flow past that point.
Right.
So the heart has to pump harder to push blood through, which leads to higher blood pressure before the narrowing. That's secondary hypertension.
Okay, high pressure upstream.
And then less blood gets through effectively to the lower body. That's hypoperfusion. So high pressure in the arms, potentially lower pressure or weaker pulses in the legs.
Makes sense. Now, these notes also mention something called pseudocoarctation. Sounds tricky.
Yeah, that's a good one to distinguish. Pseudocoarctation is where the aortic arch looks a bit twisty or kinked tortuous, we call it.
But it's not actually narrowed.
Exactly. There's no significant obstruction to blood flow, and crucially, the body doesn't develop those bypass routes, the collateral vessels, that you see in true CoA.
So it looks a bit like it, but doesn't act like it.
Pretty much. And because blood flow isn't really blocked, it usually doesn't need treatment. It's more of an anatomical variant.
Good clarification. And you mentioned associations earlier. CoA doesn't usually travel alone.
Often not, no. It's frequently found alongside other congenital heart defects.
Like what?
The big one is a bicuspid aortic valve. The aortic valve normally has 3 leaflets, but here it only has 2. That's seen in like 50 to 70% of cases. Really common.
Wow, that high.
Yeah. Also, things like VSDs, ventricular sepal defects, holes between the lower heart chambers, and it's strongly linked with certain genetic conditions too.
Which ones mainly?
Turner syndrome is the classic association you need to remember. So think bicuspid valve, VSD, Turner syndrome, key partners for CoA.
Okay, definition and associations covered. Let's move to the why. What actually causes this narrowing? The etiology.
Well, the honest answer is we don't know the exact cause in every case. It's thought to be down to abnormal development of the aorta while the baby is forming.
So something goes wrong in utero.
Right. And it's likely a mix of things, probably genetic predispositions interacting with environmental factors during the pregnancy. It's complex.
Not just one gene or one event.
Probably not. We know genetics play a role because of the link to chromosomal issues like Turner's.
Yeah.
And there might be a broader genetic susceptibility too.
And developmentally, what's the theory there?
One idea involves a sort of tissue shelf forming inside the aorta, often near where the ductus arteriosus connects.
The ductus arteriosus, that fetal vessel.
Yeah, the one that usually closes after birth. That area seems key. And remember those associations. Things like an underdeveloped aortic arch or arch hypoplasia.
Right.
Intracardiac shunts like VSDs, that bicuspid valve again, maybe even a small left subclavian artery. These often go hand in hand and point to a developmental issue in that region.
Fascinating how it all connects. Okay, so given those potential causes, who's actually at higher risk? What are the risk factors for CoA?
So pulling from the notes, definitely those genetic conditions we mentioned, especially Turner syndrome, that's a big one.
Okay.
Then family history. If congenital heart defects run in the family, the risk is higher.
Makes sense.
And then there are potential maternal factors during pregnancy. Things like certain infections, maybe rubella, or exposure to specific medications or substances, though that's less clearly defined sometimes.
So genetics, family history, and maybe some pregnancy factors. Got it.
Think genetics, family, mom's health as a quick memory aid.
Good tip. Right. Pathophysiology. How does this narrowing actually affect the body's workings? Walk us through that cascade.
Okay. Step one is the physical narrowing itself. That increases resistance to blood flow. Simple physics, really.
Like squeezing a hose pipe.
Exactly like that. The pressure builds up behind the squeeze. So the heart, specifically the left ventricle, has to pump much harder to force blood past the coarctation.
Leading to that high blood pressure in the upper body we talked about.
Precisely. Proximal hypertension. Now, downstream, the body needs blood too, right?
Of course.
So it tries to compensate. It develops collateral vessels. These are like small detour roads, trying to get blood around the blockage to supply the lower body.
Clever, but probably not as efficient.
Often not, no.
Yeah.
So you get this pattern. Increased flow and pressure before the narrowing, upper body, head, arms, and decreased flow after it, lower body, legs, relying on these collaterals.
And what does all that extra effort do to the heart itself?
That's the major long-term concern. The left ventricle, working against this high resistance, gets thicker and more muscular. It's called left ventricular hypertrophy, or LVH.
Like any muscle being overworked.
Kind of, yeah. But eventually, if it's not treated, that strain can become too much, and the heart can start to fail. Heart failure is a serious risk of untreated CoA.
Okay, that pathway is clear. Now, differential diagnosis. If a child presents with symptoms that might be CoA, what else should be on our radar?
Really important for exams. You need to think broadly, and it depends a bit on age. If the main finding is high blood pressure,
Yeah.
you need to consider other causes like renal artery stenosis, narrowing of the kidney arteries, or just primary hypertension, especially in older kids or adults.
And other heart conditions.
Definitely. Other congenital heart defects can present similarly. Think about interrupted aortic arch that's even more severe, complete break,
Right.
or various aortic valve problems.
Right.
And specifically in newborns, if they're really sick, the differential is wider. You've got hypoplastic left heart syndrome, big septal defects, critical valve problems.
Yeah.
Basically, any critically ill neonate with suspected heart issues needs urgent expert assessment.
What about older children or adults? Maybe presenting less dramatically.
Yeah, the list expands again. Could it be aortic stenosis at the valve level? Different heart muscle diseases, cardiomyopathies, maybe endocardial fibroelastosis, or just missed primary hypertension.
Oh, okay.
You might even very rarely consider things like late-presenting hypoplastic left heart, viral myocarditis, or even non-cardiac causes of collapse like adrenal problems. So always keep a broad differential based on the age and presentation.
Good point. So how common is this condition? What's the epidemiology?
It's one of the more common congenital heart defects, actually. In the UK, the figures are around 3 to 6 cases per 10,000 live births.
Okay.
And there seems to be a slight male predominance. Globally, maybe around 1 in 2,500 births, possibly higher in Caucasians, again, more often in males.
Any other patterns?
Well, genetics clearly play a role, as we discussed with family history and syndromes like Turner's. The age it's picked up really varies, though.
Depends on severity.
Exactly. Severe narrowing, especially with other heart issues, will likely show up very early. Milder cases might not be found until childhood or even adulthood, maybe during a checkup for hypertension.
Right, which leads us nicely into clinical presentation. How does CoA actually look in patients?
It's a real spectrum. Antenatally, before birth, it can be suspected on ultrasound if they see certain signs, but the notes say it's often difficult to spot definitively.
Okay. What about after birth, say in a newborn?
This is critical. Severe CoA can present in the first few weeks of life, often as the ductus arteriosus closes. The baby might become very unwell.
How unwell? What are the signs?
Think poor feeding, being really lethargic, breathing fast, tachypnea, signs of heart failure, and even circulatory collapse or shock. It can be life-threatening.
And on examination, what are the classic physical findings?
Key things to look for. Weak or absent pulses in the legs compared to strong pulses in the arms. That's the radiofemoral delay or pulse difference. Then measure blood pressure in all 4 limbs if you can. You'll find higher pressure in the arms than the legs.
The pressure gradient.
Exactly. You might also see differential cyanosis. The upper body looks pink, but the lower body looks bluish, especially if the ductus is still open and supplying deoxygenated blood downwards. And listen for a murmur.
Where would you hear that?
Typically a systolic murmur, best heard between the shoulder blades on the back or sometimes under the left clavicle at the front. These are major red flags in a neonate.
Okay, that's the severe early presentation. What if it's milder and presents later?
Often these children or adults are actually asymptomatic for a long time.
Really?
Yeah. It might get picked up because someone hears a murmur during a routine check, or they're investigated for high blood pressure.
But sometimes there are symptoms.
Yes. They might complain of headaches, maybe nosebleeds from the high pressure,
Yeah.
leg cramps, or pain when they exercise. That's claudication due to poor lower limb blood flow, or just general exercise intolerance.
And physical findings in these later cases.
Similar principles apply. You might notice a size difference between the arms if the left subclavian artery origin is involved.
Right.
Maybe weaker leg muscles, cold feet. Definitely check for that pulse discrepancy and blood pressure difference between arms and legs.
Still the key sign.
Absolutely. The murmur might still be there. Sometimes it can become continuous if collaterals are well developed. You might also hear an ejection click if they have that common bicuspid aortic valve.
Anything else to be aware of in older patients?
Yes, importantly, the long-term risk of baryaneurysms in the brain. So unexplained neurological symptoms or severe headaches warrant investigation as there's a higher risk of subarachnoid hemorrhage.
Okay, quite a range of presentations. So once you suspect CoA, how do you confirm it? What investigations are used?
The number one tool is transthoracic echocardiography, the heart ultrasound. Yep, echo. It's usually the first and main investigation. It can directly visualize the narrowed segment, assess how severe it is, measure the pressure gradient across it, and importantly, look for all those associated defects like bicuspid valves or VSDs.
So echo is key for diagnosis and checking associated issues. What else?
For a more detailed look at the aorta itself, especially the whole aortic arch, cardiac MRI, or sometimes CT angiography are excellent. They give really clear anatomical pictures.
Better visualization of the structure.
Exactly. Very useful for planning surgery or intervention.
What about simpler things like blood tests or a chest x-ray?
Yeah, they have a role. If hypertension is found, you do baseline bloods, kidney function, UNEs, creatinine, full blood count, maybe glucose to check for other causes or effects of the high pressure.
And the x-ray, what might that show?
Chest x-ray can sometimes show signs suggestive of CoA, especially if it's long-standing. You might see an enlarged heart shadow, maybe an indentation on the aortic silhouette called the figure 3 sign.
Figure 3.
Yeah, the aorta looks a bit like the number 3 because of the narrowing and the dilation before and after it. And the classic sign, though often seen later, is rib notching.
Rib notching, what causes that?
That's caused by those collateral arteries we talked about. The intercostal arteries enlarge to bypass the coarctation, and over time they can erode the undersurface of the ribs. Seeing rib notching is pretty specific for long-standing CoA with significant collaterals. Think rib notching, collaterals working overtime.
Wow, okay. What about an ECG?
ECG findings depend on age and severity. In adults with untreated CoA, you'd expect signs of that left ventricular hypertrophy, LVH, due to the pressure overload, maybe even signs of strain or ischemia. In newborns, paradoxically, you might initially see right ventricular hypertrophy because the RV is pumping against the high-resistance ductus before it closes.
Interesting. And finally, cardiac catheterization. When is that needed?
That's more invasive, so it's not usually first line for diagnosis anymore, thanks to echo and MRI-CT. But it's used if the diagnosis is still unclear, or more commonly, to get precise pressure measurements across the coarctation.
To measure the gradient accurately?
Yes, and also to assess any other associated problems. And importantly, catheterization can also be therapeutic. You can perform balloon angioplasty or place a stent during the same procedure.
Right, which brings us to management. How is CoA treated?
It really depends on the severity and the patient's age and symptoms. For severe CoA causing problems in the newborn, it's an emergency. They need immediate intervention.
What kind of intervention?
Either surgery to repair the aorta, or increasingly balloon angioplasty, sometimes with stent placement, done via cardiac catheterization.
And medications, do they play a role?
Yes, definitely. In those critically ill newborns, a drug called prostaglandin E1 is vital. It keeps ductus arteriosus open.
The fetal vessel.
Yeah, keeping it open provides a temporary route for blood flow to the lower body, stabilizing the baby before definitive repair. Also, if there's heart failure, diuretics and inotropes, drugs to help the heart pump, might be needed.
What about managing the hypertension?
Good question. In older children or adults with hypertension due to CoA, medications like beta blockers are often used both before and potentially after repair if the hypertension persists. After repair, if there's no significant leftover narrowing, ACE inhibitors or ARBs might be used for ongoing blood pressure control.
And the definitive fix is surgery or angioplasty.
Correct. The aim is to relieve that obstruction. Surgical techniques have evolved a lot, often involving removing the narrow segment and reconnecting the aorta, sometimes using a patch or graft.
And the angioplastolenting?
That's the less invasive catheter-based approach. A balloon is inflated across the narrow segment to stretch it open, and often a metal mesh tube, a stent, is deployed to keep it open.
How do you choose between surgery and angioplasty?
It's complex, depends on age, the exact anatomy of the coarctation, other heart issues, and local expertise. For neonates needing urgent treatment, surgery has traditionally been preferred for long-term results, though angioplasty can be a bridge. For older children and adults, especially with recoarctation, re-narrowing after previous repair, angioplasty and stenting are often the first choice now.
Is one better long-term?
Surgery in neonates might have lower rates of needing reintervention later, but angioplasty stenting is less invasive initially. For older patients, stenting is effective but might have its own long-term issues like stent fracture or aneurysm formation near the stent. There's also evidence that balloon angioplasty can be quite cost-effective in children compared to surgery initially. It's an evolving field.
Okay, so assuming treatment happens, what's the outlook, the prognosis?
Generally, with timely and successful repair, the prognosis is very good. Most people can live relatively normal lives.
That's great news.
It is. However, and this is crucial, lifelong follow-up with a cardiologist is absolutely essential.
Why is that if the repair is successful?
Because problems can still arise years later. And comparing that to untreated CoA, the outlook is starkly different.
How different?
Untreated severe CoA has a very poor prognosis. The notes say less than 20% survive beyond 50 years old. The strain on the heart, the hypertension, the risk of aneurysms, it takes its toll.
So treatment is life-changing.
Absolutely. Factors like how old the person was at repair and how long they had high blood pressure before treatment do influence long-term survival, even after repair.
And what are those potential long-term issues people need monitoring for?
The main ones are recoarctation, the narrowing coming back persistent or new onset hypertension even after repair, aneurysm formation in the aorta, especially near the repair site or stent, and a higher risk of premature coronary artery disease and stroke.
So ongoing checks are vital.
Yes. Blood pressure monitoring, regular echo checks, sometimes MRI scans. Lifestyle advice is also important, usually avoiding very heavy lifting or contact sports, but encouraging regular moderate aerobic exercise. And a special note for women.
Yes.
Pregnancy after CoA repair is considered high risk and needs specialist management due to the stresses on the cardiovascular system. Unrepaired CoA carries a very high maternal mortality risk.
Understood. Let's list out those potential complications again, just to be clear. What can go wrong with CoA before or after treatment?
Okay, so the list includes recoarctation, re-narrowing, persistent hypertension, aortic aneurysm formation, aortic dissection, a tear in the aorta wall, very serious, higher risk in pregnancy, rupture of cerebral aneurysms, aneurysms, also higher risk in pregnancy.
Cardiovascular ones mainly.
Yes, and also congestive cardiac failure from the heart strain, infective endocarditis, infection of the heart lining, especially if valves are abnormal, rarely spinal cord ischemia leading to paralysis if blood supply is disrupted during repair, recurrent laryngeal nerve injury causing voice changes, endocardial fibrinolysis, hypertrophic cardiomyopathy, and postoperative issues like chylothorax, lymph fluid leak, or mesenteric arteritis, inflammation of gut arteries after flow is restored. It's a broad range, highlighting why lifelong care is needed.
Definitely. Finally, before we wrap up, any thoughts on prevention or the importance of early detection?
Well, since the exact cause isn't fully known, primary prevention isn't really possible. But early detection makes a huge difference.
How can we improve that?
Prenatal ultrasound can sometimes pick up suggestive signs like an enlarged right ventricle or specific aortic arch views, prompting closer checks after birth. But the most crucial thing is that thorough newborn examination.
Checking those pulses.
Yes, carefully feeling the femoral pulses in the legs and comparing them to the arm pulses. Any weakness or delay should raise suspicion. Some guidelines also recommend forelimb blood pressure checks in newborns if there's any concern, or even routinely. Catching it early, before the baby gets sick, leads to much better outcomes.
So that newborn check is absolutely critical.
It really is.
Okay, let's try and summarize this deep dive on coarctation of the aorta. It's a congenital narrowing, usually near the left subclavian artery.
Right, causing higher pressure before it, lower pressure after it.
Linked to genetics like Turner syndrome and often other heart defects like bicuspid aortic valve.
Presentation varies hugely from critical illness in newborns with weak leg pulses and shock,
to being picked up incidentally due to hypertension or a murmur later in life, sometimes with symptoms like headaches or leg cramps.
Diagnosis relies heavily on echocardiography, with MRI or CT for detailed anatomy. Chest X-ray might show late signs like rib notching.
Management involves stabilizing newborns with prostaglandin, then definitive repair, either surgery or balloon angioplasty stenting, depending on the situation.
And prognosis is generally good with timely treatment, but lifelong follow-up is non-negotiable due to risks like recoarctation, hypertension, and aneurysms.
Excellent summary. A complex topic, but hopefully that breakdown helps everyone listening with their MSRA revision.
Absolutely. And don't forget, for more MSRA preparation, do check out pastthemsra.com.
And freemasra.com as well.
Yeah.
Great resources there.
Definitely worth looking at.
So a final thought to leave you with. Coarctation teaches us how a localized anatomical issue can have such widespread systemic effects. Always think about the connection between upper and lower limb pulses and pressures. Sometimes that simple check can uncover a significant, treatable condition. Keep digging, keep learning.